All right, so who needs mechanical ventilation? So when a patient can no longer ventilate or oxygenate on their own, they'll need a mechanical ventilator to take over. It's really important to understand that a ventilator is a closed system. And this is really important when it comes to when we talk later about inline speaking valve and what we as speech pathologists do to change that closed system. So just understand that a ventilator is closed, meaning that it delivers a preset volume or pressure through the inspiratory circuit for the inhale, and then that air is then exhaled back to the ventilator through the expiratory circuit. So what goes in, the preset volume or pressure that is delivered in, must come out. And the ventilator measures both that inspiratory volume, tidal volume and the expiratory tidal volume, and it really wants that to match closely. If it doesn't, then it's going to start alarming and tell you that there's something wrong. Okay, we've talked a lot about minute ventilation, and we think it's really important because when you're looking at recruiting appropriate patients for inline speaking valve, oftentimes, especially if you're building a program at your facility, we as speech pathologists are going to be the ones to recruit the appropriate patients and educate staff on who is a good candidate versus who is not. And we think minute ventilation is a really good way to just a kind of a quick way to look at vent settings and tell how hard is the patient working to ventilate, and maybe like how sick they are. So minute ventilation, as Thomas described, is the volume of gas that's inhaled and exhaled in 1 minute. And that is your respiratory rate times your tidal volume. So my minute ventilation right now is different than Thomas's minute ventilation or Rory's minute ventilation, because I am speaking, I'm sort of exerting myself a little bit more, probably taking different sized breaths depending on where I'm stopping when I speak, whereas Thomas is sitting at rest. He probably has a pretty even respiratory rate right now, pretty consistent tidal volumes with each breath. So his minute ventilation would be different than mine, right? Minute ventilation dictates carbon dioxide clearance, right? So if you have a big minute ventilation, that's telling you the patient may have trouble getting rid of carbon dioxide. And that would make sense, right? Because we know respiratory rate times tidal volume is what minute ventilation is. And if we have a high respiratory rate, we know that's targeting that ventilation or carbon dioxide removal. Again, this is different for every patient, but it can be a quick way and kind of go-to figure out how sick maybe your patient is on the ventilator.
So that's what we're going to do here. Let's talk about this vent. Is this patient, do they look good or bad, quote unquote, right? So they have a rate of 30, which is high. They have a pressure of 18, which is okay. They're in pressure control mode. Their PEEP is 12, which is on the high side, and their FiO2 is 60%, which is on the high side. Their respiratory rate actually is 36, which is high. Their tidal volume is 381, which is okay. Their minute ventilation is 11.1, which is okay, but that's really because the tidal volume is low. The respiratory rate is actually pretty high, so, it's all relative. And the PIP is 33, which is okay. Thomas, reading this vent, what might you think about this patient's underlying respiratory or pulmonary issues?
This patient certainly has some trouble with CO2 elimination. Respiratory rate of 36, that's pretty high. Minute ventilation of 11, that's a little higher than it should be. Normal minute ventilation is about 5 to 6. So they've got a higher minute ventilation need, but their biggest issue is probably oxygenation. So the PEEP of 12 is pretty high. Once you start getting into PEEPs above 10, that's a fair amount of PEEP. FiO2 of 60, it's not too high, but it's on the higher range. So I would say this is somebody who's having issues with both oxygenation and ventilation, but more an oxygenation issue than a ventilation issue. Also looking at their pressure control of 18, while that's not an incredibly high pressure control, they're only getting tidal volumes of 380, which isn't too big of a tidal volume for that much pressure. So definitely this patient has some issues with generating tidal volumes from that much pressure, which is either going to be due to low compliance or high resistance. And just looking at their oxygen requirements, this is probably a low compliant patient, meaning they have stiff lungs, like an ARDS type process. they're having a really hard time oxygenating and also not getting very adequate tidal volumes for the amount of pressure that's being given by the ventilator.
Okay, so we have a bunch of examples here. There's going to be 2 slides. You can use these to sort of quiz yourself and go through and write in the numbers, the mode, rate, pressure, PEEP. And then we have this question of like, are they an InLine candidate based on that chart that we gave you, right? And I won't wait too long because I don't want to take too much of your time, but so this patient's in pressure control. The rate is 32. The pressure is 20. The PEEP is 16. The FiO2 is 55%. Tidal volume 478. Minute ventilation 15.3. PIP 38. And I didn't say this, but their actual respiratory rate is also 32. So are they an InLine candidate? No, they have a high respiratory rate. Their PEEP is very high. Their FiO2 is getting up there pretty high. Their minute ventilation is high and their PIP is high. Pretty much everything's very high in this case. So probably not a great candidate.
But how does inline passing air valve or inline speaking valve change the vent function? So it changes this closed system, which is why the vent does not like it, and it'll alarm and make lots of noise and let you know that it doesn't like that, which is why we need respiratory therapy there, of course, and we need to do some compensation, right? So the cuff must be deflated when a PMV is in place, and like Rory said, that is whether you are on trach collar trial or on the ventilator. So with the cuff deflated, airflow then is exhaled through the upper airway upon that exhalation. However, the inspiratory circuit still delivers the preset pressure or volume that the vent is set to do. However, the vent recognizes that there is a leak in the system because we deflated the cuff and it's going to alarm, right? The leak is seen as a significant drop in tidal volume. So when that cuff is deflated, the tidal volume is going to tank, hopefully, right? We want to see a loss of tidal volume because that means the patient has upper airway patency. The loss of tidal volume is kind of like your test if you were doing a trach collar trial patient with PMV when you do finger occlusion, right, to see if they have audible voicing or have upper airway patency. This is the same as that sort of test, right? The loss of tidal volume will tell you that they have upper airway patency and then that you can proceed with actually placing the PMV inline the vent circuit. But the vent does not like that, as I said, right? It's going to start screaming at you, lots of alarms. You can see this is a picture of a ventilator when the cuff was deflated to start a inline PMV trial. This one looks really bad because the respiratory rate's 50. Don't be alarmed. We'll explain this more. The vent was auto-cycling when we took this picture, and we're going to talk about what that means when we discuss troubleshooting, because this very well may happen to your patient with cuff deflation, especially if they're in a control mode of ventilation. But you'll see on the top that low tidal volume alarm, it's going off, everything's, making noise, and it can feel like a tense moment when you're in the patient's room, especially when you're first starting to do inline speaking valve trials. Do not be alarmed. And just keep moving forward. You're going to watch vitals and everything else we'll talk about in a minute. But you'll see with the cuff deflation, right, the tidal volume dropped pretty significantly. It's 127 in this picture. The PIP dropped to 26. So that's what we want to see. We want to see that loss of tidal volume. Okay, so what can we do when we're in the room? A lot of what is happening is the respiratory therapist is working the vent, and we may be there to offer suggestions and kind of gently suggest what we would do if it's not as much of an experienced RT. But things that we can do for the patient is if they're having poorly coordinated voicing, you could demonstrate phonation upon the exhale. They may have difficulty coordinating. They may start to try phonating like on the inhale. So just kind of reteaching to phonate on the exhalation. You can do synchronized like inhale, on the exhale, right? So like relearning to phonate on the exhale. You will be monitoring for that increased PIP. So that would indicate decreased upper airway patency. So if you see that PIP, it starts at 18 and over time it's creeping up to like 20, 21, we know something's, they're not getting upper airway patency or enough upper airway patency to completely exhale their breath. In that case, you'd want to remove the speaking valve, put them back on their vent, and then consider the size of the tracheostomy tube positioning. Do they have a lot of secretions that's causing some decreased upper airway patency? So we're monitoring that. If the patient has significant coughing, upon the next trial, you could, see, do they need some sort of medication? Would like Mucinex or something help them just be on board for something? You could consider doing the InLine and oral sectioning as needed. And then something that's really great, and we will touch on this a little bit, but doing expiratory muscle training for their cough strength while they're using InLine speaking valve is a great therapeutic tool. If the patient has a lot of anxiety, you could coordinate and speak to the doctor about if there's any just low dose medication options to help them through some trials. Very slow cuff deflation helps with anxiety. It just allows the patient to acclimate without this immediate, fast cuff deflation, the whoosh of air, the coughing, the alarms, the everything. Slow cuff deflation can be really helpful. And then just guided relaxation and breathing techniques are helpful as well. But anyway, looking at vent adjustments for this patient, Thomas, what do you think?
So similar vent settings. The previous example had a pressure support of 10/10 and 40%. This is 10/5 and 30%. So this patient's oxygenating better than the previous example because they're using less PEEP and less FiO2. They're both using the same level of pressure support. But the big difference between this patient and the previous example is if you look at this patient, their respiratory rate is 28. The previous example had a respiratory rate of 14. So this patient is already tachypnic. Anything above 20 is tachypnea, and once you get above 30, you're starting to get into pretty severe tachypnea. So they're already pretty tachypnic, and they're getting tidal volumes of 300, which are not the most robust tidal volumes. So just looking at this is somebody who's absolutely appropriate and will probably do well, but I would also anticipate that this is somebody who might need some vent adjustment, whether that's more pressure support, maybe a mode change to pressure control to give them more support that way. Again, you sort of just got to put the valve on and see what happens. They might do fine, you never know. But just walking into it, in my head, I'd be going, okay, this is somebody who I might need to give some extra support to once the valve goes in.
Mm-hmm. So giving a little bit more pressure would hopefully increase their tidal volume some and maybe bring down their respiratory rate a little bit. But, who's to know? But that's something you may trial. We turn the PEEP completely off, and we know PEEP targets oxygenation. We have lots of wiggle room with the FiO2 if there were mild desaturations, right? If your patient starts satting down in the low 90s, high 80s or whatever, just relative to them, whatever is reasonable, you can turn up that FiO2 a little bit, right? You got lots of wiggle room to compensate with that. Of course, you can decrease trigger sensitivity if they're autocycling. I wouldn't really anticipate autocycling a lot again, but just some different things you can do and things to consider. So now I'm going to demonstrate how to actually put the pathophysiology valve or the speaking valve in line. So on this setup, you can see the suctioning is going into this way. I often like to keep that suctioning available, so I won't hook the PMV up there or anywhere else. I like to keep that line open. So what I would do is remove this corrugated tubing, and then I would need a 22x15 adapter to put here in which to connect the pathophysiology, and then to connect this corrugated tubing, or I guess I could use that one too, into the, put it in line. So I'll do that now. I have it all pre-assembled to make it quick and easy. So that is now in line. I'll silence the vent because it's detecting it does not like that. And that's how you would hook a pathophysiology valve up in line for this setup. All right, for this setup, I'm going to show you a little bit different. We don't need that 15x22 adapter. You'll still see I have the inline sectioning available for the patient as needed. I'm going to disconnect this corrugated tubing, but then the pathophysiology will fit right onto that, that adapter there, that hub. So I'm going to remove this. You'll notice I always try to remove it on an exhalation, so I'm not taking it off while air is being delivered. You may get some aerosolization or splash up if you do that. So I try to always change it on an exhalation. The other thing you could do, of course, and which we have all our respiratory therapists do, is just pause the vent briefly while you're doing all that switching and changing. So we're going to do an inline speaking valve. Here's his baseline vent settings: pressure control 18/10, 50% FiO2, a rate of 20. See his tidal volumes 402 to 477. Minute ventilation is 15.6. Peak inspiratory pressure is 32. So we will start by turning down the PEEP. We're just going to reduce it by 5. And then we'll go ahead and respiratory therapy will deflate his cuff. And then he'll probably get a little post-cuff deflation section if needed.
Yeah, and I collected them too. Yeah.
We're going to increase the FiO2 to 100% during this. And we're going to see that tidal volume is dropping really low because he has great upper airway patency, so he's losing that volume, as well as his peak inspiratory pressure. RT is suctioning right now. So this is what we want to see on a ventilator. All right, so he is suctioned out, his cuff is deflated. Respiratory is going to change him into spontaneous mode because he did really well with that yesterday. So we're going to take that rate off. All right, so we're in spontaneous now. Pressure support 10/5. All right. So we'll take his quick switch here.
Thank you.
How you doing?
All right. You just coordinate that breathing for a few minutes. You look great. You're welcome. The vent's alarming because it doesn't like that there's no expiratory flow. And if we just look at the vent, you'll see he's on this spontaneous mode, 10/5. And then that, expiratory tidal volume is, non-existent here. So one thing we do like to look at is his PIP. We'll want to make sure that that doesn't start increasing. If that does, then we may see that that's, maybe some air trapping, or he's not getting the expiratory flow out of his upper airway. And then we'll look at his vitals. His heart rate's 95, O2 stat's 98, and we know his respiratory rate is 19 by looking at the vent. He looks great.